έχουμε μαζί μας ένα συνάδελφο από το Πανεπιστήμιο της Κοπενχάγης, με το οποίο συνεργαζόμαστε από... Is it called data science? The department? Your department?
Computer science.
Computer science. Οπότε, από το department του Computer science στο Πανεπιστήμιο της Κοπενχάγης. Ασχολείται, το όνομα το βλέπετε, είναι Tariq, Osman, Andersen. Ασχολείται με θέματα επεξεργασίας βιωτικών σημάτων και επίσης με θέματα user experience, πώς δηλαδή δημιουργούμε εφαρμογές επεξεργασίας σημάτων, οι οποίες είναι φιλικές προς τα χρήστη. Σήμερα θα μιλήσει για τεχνητή νοημοσύνη στο κομμάτι αυτό και θα παρουσιάσει μια δουλειά που έχουμε κάνει στο Πανεπιστήμιο στο σχετικό αντικείμενο. Είναι κομμάτι της φύλης και της φύλης που μας έχει σίγουρα και της φύλης. Γι' αυτό και τα κάναμε. So, I introduce you, but maybe you want to start by saying a few things about yourself, what you do, and why you are here. Sure. How did you find your way to Lausanne all the way from Copenhagen, and then, you know, do the video presentation.
Hello, everyone. I'm very honored to be here and give a talk to you. So I'm visiting from the University of Copenhagen in Denmark, and I'm going to talk about why it's very difficult to realize. So, you know, having success with systems that are based on machine learning in healthcare domain. So, and when I talk about that, I'm talking about having success getting adoption in a clinical setting. So my background is in software engineering, and since I did my master's, I've spent a lot of time in human-computer interaction, and mostly what I do is that I do field studies. So I go and visit patients' homes. I go to the clinic to understand how clinicians work. And then I translate that into usually some kind of user interfaces together with clinicians and patients. And then I engage with the developers and the engineers to develop the systems. And then we usually bring them in to some kind of live situation, or like in the hospital, or in a hospital setting, or running in the hospital. So basically, my research is within human-computer interaction, usually drawing on qualitative methods. So I hope this makes some kind of sense. So just to say, this picture is from some of the field work that I've done. This is in Africa, in Kenya, where we travel to meet radiologists to discuss with them what would an AI-based system, you know, how could it help their decision support. So I'll talk a little bit more about that later. But first I'm just going to talk a little bit about the problem that I'm going to talk about. So if you look into PubMed, you know, the database for research papers in the clinical domain, then you'll see a huge increase in publications or studies that have AI in the title. So just, you know, in the period between 2018 and 2020, so in this 2-year period, there was a 10-fold increase in papers with AI in the title. But if you then look at, you know, how many systems are actually approved in the US and in EU to run in the clinic, so how many systems based on machine learning are actually approved to run in the clinic, then it's very few. So I think there's an overlap between, you know, systems that are approved in the US and in the EU, so there's around maybe 300 systems approved in this period of time. So the story is, we have a lot of promise shown in laboratory studies, but there are very few systems that are approved to run in the clinic. And then if you think about it, very few systems are then in use routinely. So it might be that they are approved, but having them run in the clinic, you have even fewer systems. So I'm going to give you a few examples of some of the reasons for why it's very difficult to have success with machine learning-based systems in clinical reality. And this is one, out of the many published papers that document, great opportunities with machine learning. This is people from Google Research, where they have a very cited paper where they describe, they can predict blindness among diabetes patients. So it's called diabetic retinopathy. And so these people, they came out with a study showing great promise with machine learning in diabetes. Then that same group of people invited some let's say, human-centered evaluation people on board to look at what happens then if you bring this into the clinic. So they had a large prospective study running in Thailand with 11 clinics involved, where they deployed a deep learning system. And in this paper, they describe what they call all the sociotechnical issues that emerged when they brought the system live. And just a few examples from that paper, simple stuff like when they take the picture, they usually have a long waiting line of people coming in to have the iris image taken. And then sometimes they forget to turn off the light. And then when they send the image, it's in a poor quality to the AI algorithm, and then it's not able to come with any output. So if they're not able to produce a good image in the clinic, then the algorithm doesn't perform very well. Other examples, are like poor internet connectivity. If there's a breakage in internet connectivity, then the AI algorithm will not work. So there's a lot of very, very simple, issues emerging, making this not working as anticipated in this prospective study. So, this has been called the last mile problem of medical AI. So, we're quite good at capturing data, cleaning, labeling. We're also quite good at building models and showing, the performance in a laboratory setting on retrospective data. But we're not very good at having, machine learning-based system running successfully in routine use in the clinic. So this is why I'm trying to talk a little bit about why is it so difficult. But I'm just going to give another example from my own work. So this is some work that for some reason went all the way to the news, to the Danish news media, and here they describe the case that I'm just going to talk shortly about. So here it says, a new tool is going to help the doctors, AI tool. Okay, so the case is patients who have an implanted cardiac device, which is called an ICD, and they today can monitor from home with a monitor box. They can hold a small mouse up to the skin here, and then you can transmit data to the clinic. So that's called remote monitoring, and so it picks up a lot of data from the implanted device, and then some years back we collaborated with Medtronic, who makes these devices, and we got a huge data set from around 20,000 Americans who had an implanted cardiac device, and we got the data to work out some algorithms to predict some of these dangerous cardiac arrests, you could say. So this is just an example of a paper, again, similar to Google, where we demonstrate you can actually predict this cardiac arrest 4 days before it happens. So it looks very promising. And then this is a little bit the situation the clinicians are in. They receive data and from the device, and then they have to spend some time looking through all the data and decide what to do. So what we wanted to experiment with is, what if they could know in advance, of a cardiac arrest? What if they could know the risk of this happening within 4 or 30 days? So this is a mock-up that we did. So we had the model and that worked out, but now we need to work on the interface. So this is one transmission of data where you have the date and the person and so on, and then we are working with just very simple, indicating if there's a high, medium, or low risk of these arrhythmias coming up in the next 4 to 30 days. So again, this is how it could look on a mock-up. And then, okay, so then usually what you would do is that you would implement the model in the system, and then maybe if we did like Google did, then we would have a prospective study running in the clinic, and then maybe we would encounter a lot of issues like Google did in time. But instead what we did was that we quite early on, tried to put the AI on paper, so to speak. So we made, for particular patients, some predictions. So this is how it would look, risk of cardiac arrest, basically. And then we would say, is there an alarm? Yes or no? What's the percentage of chance that this will happen within the next 30 days? And then we would have the data counting for and against the risk. So the data captured from the ICD, so that we could explain to the clinician why this might or may not happen. So we had several pieces of paper for several patients, and then we did this. We had around 7 of these specialized cardiologists to look through the patient case, and then we, on paper, everything on paper. And then we gave them the prediction to discuss with them, how would you react if you got this AI prediction. So in this way, we very early on in the project could try to explore, what will happen if they have a prediction available from the AI. So again, a lot of discussion, a lot of exploring what will happen, and a lot of feedback from the clinicians very early on. So this is a paper describing, then unpacking a little bit, or to a quite large extent, what's going to happen when we bring in this machine-based system near live, so close to a real clinical setting. And then a lot of stuff going on here. I'm trying to just give you the main points here, okay? So we had 4 questions in this paper. And we had 5 cases. So what we found, for example, we asked them, does this AI prediction support your decision making? Does it help your work in deciding what to do with that patient? And then on some of the cases, we had 86% and 100% answering, they agree this is actually quite good. This supports my decision making. So just an example. So some of the cases, some of the patient cases, it was actually beneficial. But then, on some other patient cases, this tool, they didn't answer that much, they didn't agree that much that it helped them. So this slide, you don't need to understand all the details, but it's just to say that the AI was useful for some patient cases, but not useful for other cases. So very simple learning, telling you that the machine learning-based system might work for some types of patients, not everyone. So this is good to know quite early on. So beside this questionnaire kind of output, we also, explored the different sociotechnical issues that could emerge. And now I have put on a quote here, and I'm going to invite you a little bit to spend a few minutes reading this, and then maybe talk to your neighbor about what do you think is going on here, what can we learn from this quote? And then we can discuss it a little bit. So you just need to read it and discuss 2 to 5 minutes with your neighbor. What do you think is going on here? Or what would you suggest? You can interpret many things here. Should we try to talk about it? So anyone has some things they want to share about what's going on here? Do you want to?
Yes. Because a doctor might have many medical cases and sees the success rate of prediction of an illness by I'm sorry, AI is over 60-70%. If the doctor doesn't have enough time to spend on all the medical cases, then using AI can be on average very beneficial and could potentially save and potentially save someone.
Yeah, sure. Yeah, so I think what I'm getting from what you say is that the AI can maybe help prioritize some patients, that these patients need more attention. So that's something definitely I'm also going to come a little bit back to that later. So I think the first sentence suggests something like that, right? That that it affects him a little bit, that he might, be a little bit more concerned about this patient. He might react a little bit more aggressively, he says, right? So it orients attention to this patient. So I agree. Any other things? Yeah.
I think that the point here is that this whole AI alarm is going to cause nervousness both in the doctors and the patients, and sometimes if the doctor has a full schedule, he cannot,
Yes.
he had to trade off
Yes.
the volume.
Sorry, it's rapid. It's exactly so. So what you're saying is, I'm trying to translate a little bit. You're saying that the AI might do some good work, but on the other hand, there's still a patient schedule with patients booked already. And what this doctor is saying is that, well, I still have the schedule. I mean, there's other patients on that schedule. So, I mean, basically, he's still dependent on, can he take the patient in at all? Is there any time? So it might be that the AI says you have to do something about this patient, but then the doctor says, yeah, but I still have a lot of other patients. So what this says a little bit, or you could infer, now I'm just going to jump to the point, is that the usefulness of these predictions, they depend on the clinical setting. So if you are, in Denmark, in this university hospital that maybe has a lot of resources, you have this opportunity if the AI predicts something. If you're in another hospital that maybe don't have that many resources, then it might not be, useful at all. So it's a very simple point, but it's just to say that, it might be that we can predict many things, but still have to consider the local clinical context. Is it possible to do something when we predict something? So that's just the simple point I want to make with this. So thank you. Okay, I have one more. Okay, I have many quotes, so I hope this one is maybe a little bit easier actually. I don't know. So can you just spend a few minutes reading this one and discussing? Thank you.
By introducing these kinds of technology in experts, they start depending on them, and they end up relying on them. So they do half of the work that they have to do sometimes. So the result is not the best they can give, because they rely in a big percent in these kind of technologies.
Yeah, so what you say is that after some time they get dependent on the technology, and they just, as this electrophysiologist says,
Yeah.
they just look at what does it say. So, and then maybe over time you're saying a little bit they maybe become de-skilled and not that good, or am I over translating? Yeah, okay. So that's one issue, yeah.
And they are trained in different things from other fields. They're not physiologists or doctors. They are something between biomedical engineers or cardiologists, for example.
So you mean if you're trained in something, you might be able to use this system because you can just look at the output. You don't need to be an electrophysiologist. Okay, yeah, that's an opportunity, yeah, that you could use this system with, other types of roles than a very specialized doctor. But then, we need to be able to rely on the technology. So if we can rely on it, then maybe it's good. So that's right. Thank you. Any other comments on this one? Yeah.
Maybe it's about how doctors develop trust, more refined models after some number of months.
Yes.
They tell me the outputs because they are sure that it is correct, that is most possibly correct.
Exactly. Yeah. So that's an important point, because AI and trust is a huge topic, and it's approached by many different fields, and explainable AI is one field, and so on. And many times we think of trust as something you gain from a good interface, for example. But what he's saying here is that it's something that emerges over time. It's not something that you gain, from one day to another. It takes time to get trust in the system. So that's a good point. Yeah, thank you. It's what he says here. Yeah. Any last comment? Yeah.
Some doctors established in their field might have their own methods of applying medicine and are not accepting of something new.
Sure.
It works, so why innovate? Why do something new?
Sure.
That's
Yeah, so
semantic might help them to understand.
yeah. So that maybe can be read out of this, individual clinicians might have particular attitudes to AI, and for some, they believe in it and then they trust it. It might be that we have another quote where they don't trust it over time. So that's also important to understand, that you don't have an AI system and then, you establish trust immediately among many clinicians. It might take some time and be individual. I think, yeah, so the point here is trust is established during the use of the system. It's not something that comes out immediately, firsthand. But I think the last point, was back to maybe the first comment. So something, there might be opportunities here. It sounds good that you can, just look at the output from the AI prediction. But this also introduces something called automation bias, which means that, as he says, over time we'll just look at what does the AI say. So back to the de-skilling kind of thing. This happens for, let's say, 10 years. Then maybe after 10 years, this electrophysiologist might not be as good as he was, 10 years ago using this system. So we have to take that into account. Okay, so now I'm gonna, jump from the two examples from some of the Google work and some of my work, and then to looking across different studies that try to implement machine learning-based systems in near real clinical reality or in the clinical setting. And then I'm going to try to walk through, many things, so you have to bear with me. But I'm trying to answer the question, why is it so difficult? Why is it uniquely difficult to introduce or to design, develop, and implement machine learning-based systems in clinical contexts? Because as I said in the beginning, very few systems are out there in routine use. So why is that? I'm going to try to go through that. So it's based on a literature review that we did, my PhD student and I, and some clinicians, and an expert in machine learning. So this is a very long paper published in a journal of human-computer interaction. And in this paper, we go through many things, but we discussed, what are these particular challenges that are met when we implement these systems in clinical reality. And we look across 25 studies, and I'm just going to try to give you some of the points and not too much about our method and so on. So this is kind of the backbone of what I'm going to talk about. So, 6 areas. One area, these 3 areas are maybe the technical areas. These are more the social areas. So we try to divide it up a little bit. So here we have training data, model building, building the models and so on. Maybe also looking at the performance of the model retrospectively, only on data. Here we have an area about, integrating the machine learning model in some kind of clinical system, software system, so that it can run somewhere in the world, in the hospital. But that also means, the AI models needs to draw on, live data or production data from that clinic, and not make it different from the training data. So system integration and data use. Third area, the user interface. That needs to be designed and developed. It needs to be, visible for the clinician. Here we have opportunity to bring in contextual information around the prediction, for example. We also can give explanations. There's a lot of algorithms that can unpack and create transparency on the models. So here, the user interface. So these are some technical areas. Then on the social side, you have the user. They can have some attitudes. Someone talked about that. They can have particular I don't like AI attitude. They can also have I really like AI because it knows me. But they have attitudes, but they also have different needs. A nurse might have different needs than a specialized cardiologist for looking at the same type of patient. Very simple thing like training. If you're not trained in how the AI system works, you might use it or not use it. Workflow and organization. So, typically it's not only one clinician, doing something on a patient case. It's kind of a workflow and collaboration. Maybe that's what I want to say here. On the broader perspective, you have regulation. If you want the system to run in a real clinical setting, it needs to be approved and follow some, regulatory constraints. There's also ethical issues like how do the clinicians see it impact, patients' lives, and so on. So, these are some areas that can affect the success or not success of an AI-based system. So I'm just going to walk through five of these, and what I'm going to try to illustrate a little bit is the connection between the technical and the social. So I'm going to try to give some examples that show some socio-technical challenge. So usually the challenge is not only technical or only social, it's kind of a dependency. So do you remember the first example I gave where the doctor was dependent on the patient's schedule? So you might have a very good performing algorithm, but still you're dependent on the clinical context. So here I'm trying to draw some connections. It's a little bit complicated, but I think the overall aim you will get. So, 5 of these socio-technical interdependencies I'm going to give you some examples of. More quotes. I'm sorry. Okay. Here, this is one quote from one study that tried to implement some kind of AI. I don't remember exactly what system it was. It's not very important, but the physician says the quality of the electronic health records collected in Chinese hospitals were much worse than those in the Munich public data set. So here we have a situation where there's a physician using some AI system in a clinical setting, and he or she is aware of that system or that model algorithm being trained on, data coming from electronic health records from Chinese hospitals. And this person says he or she is concerned because that data is very poor. It's even worse than a public data set. So, during use, and if you're aware of the data collected, you can, still be concerned. So, some of these points you might know already, but, poor training data generated concerns when using the system. So, it ties all the way out to when you use the system, if you know how the system is trained, the model is trained. If the model is inadequate, it could lead to confusion. Also something that happens during use. So there's kind of a connection between, training the model and the data that you have available, and then using the system. So this is, training the data and using the system. I'm just trying to illustrate that there's a connection that we need to be aware of. So when we start training the system, we should maybe also consider the use of the system. What will happen when we use the system? And the same with the 2 other examples. So system integration, workflow, and then user interface and use. You don't need to understand all the details, you just need to understand the connection between the technical and the social. This is another quote. I think this is from intensive care kind of system, AI-based systems that can, raise an alert on some patients that need specific attention. And this says, for me to have to track the physicians down to give them that information would be burdensome, and that's what would get in the way of the flow of the emergency department. Also, it's emergency department. Okay, so the point here is, you know, the system might come up with an interesting or good prediction, but you know, it's not that valuable that the nurse wants to run around in the clinic to get the physician to attend to this case. So, you know, you might have a system that works, you know, in the lab, but then when you integrate it, it doesn't really work because they're not going to use it. So what we saw across the studies is that, you know, it could lead to these AI-based systems could lead to additional time spent and feeling overburdened. So they need, you know, they need to work more kind of with the AI system. Poor timing, you know, when do you get the alerts? When do you get the prediction is also very important. So, for example, in sepsis, you know, in intensive care, when do you get the alert? Do you get it too late, or do you get it, you know, on the exact time that you need? Is also very important. If you get it in the wrong time, it's not going to work. I think some of you commented on this on the other quote, where you could read it a little bit, but this one is about, you know, it might bring more attention to patients that you don't want to spend time on. So, in some cases, then, you know, the staff would need to hire more people simply to be able to attend to all the alerts that they get. So this is another quote again. So this, I'm just going to read it out. Nurses said that they became very careful about documentation due to the thoughts that the data that they enter will be used to infer risk of falling. So this just suggests, you know, that some nurses, when they implemented this AI-based system, they got a bit concerned because when they were writing notes on a particular patient, you know, documentation work, that data would be used by the algorithm. So they started to get concerned about, you know, are they writing the right thing and so on. Simple things, but quite important. So this says something about clinical accountability. You know, for the nurses, they get anxious about if they're doing the right work. So it challenges them when they do the documentation, for example. What we also saw in our studies that it's very famous, but you know, if it's not well explained, if they don't understand why it's predicting as it does, then it's also going to fail. Many times, you know, the prediction alone is not enough. We need contextual information. We need information around the prediction to be able to understand why. Last point is some machine learning-based systems were developed so you can interact with them, so you can, you know, explore the prediction. But what they then found is that some clinicians, you know, when it didn't go well, they started to interact with it until it came up with a result that resonated with what they believe. So this could be, you know, introduced confirmation bias. So they're trying to tweak it so that it comes out with an output that they like. Small things, but very important to understand. Okay, so now I'm just gonna take the two last examples. Sorry, this one. So this is a doctor saying, we doctors spend years in school to learn how to make a diagnosis based on those traditional statistical tools and diagrams. Your tool is obviously more informative. We just need more time to get familiar with it. So this is back to the training thing. You know, if they don't understand the system, they're not gonna, you know, use it as suggested. We also talked a little bit about this, the attitudes. If the clinicians don't believe in AI or are not convinced, then it might also fail. Diverse clinical roles, diverse clinical needs. We talked about that. If you're a nurse versus if you're a specialized electrophysiologist. So I think this is my last quote today. So this is back to the Google case where they tried to predict, diabetic blindness. And something that happened for quite many cases is, I'm just going to read it out. Some nurses felt the need to warn patients that they would need to travel should a referral be given. So if the prediction was raised, they need to give a referral to another hospital. Given the far distance and inconvenience of getting to a tiny hospital, 50% of the patients at one clinic opted out of participating in the study. So, what this just suggests is that the nurses were aware that this was introducing a lot of issues for the patients if they had to travel only some kilometers to another hospital. So they're simply not able to do that compared to the value that they would get. So they would, actually suggest patients to opt out of the study. So the point is that you might have a good, AI prediction, but, locally, how is it going to affect the ethical considerations? Maybe just, so this is the ethical considerations, and then maybe one thing here also very important to be aware that, you might develop a system in one country. For example, I'm in a project where we work with radiology, findings in a chest x-ray, and if you compare how we label it in Denmark to how they would label it in Kenya and Africa, they would do it very differently. So if there's and in other domains it's much more complicated, so if there's weak consensus on the medical definitions, if you're in a field where the consensus is weak, then it's very hard to train a system that works globally. So that's something to keep in mind. What's the domain you're in, and is there a strong consensus on medical definitions? That will affect, how successful will you be. So these are the interdependencies. It's also in the paper. And now I'm just going to end up with a few examples, how we try to work against those issues. So this is early on in one project where we are developing, let's say, an AI algorithm that can detect findings in a chest X-ray. So radiology, is quite famous for having success with machine learning, and in this project, we have a model at some point in early on in the project, but then very early also I just show them an X-ray image where the AI points out where there's a finding. So that's the only thing I bring in those images, in those examples, is how AI will highlight something, and then I start a discussion. Will this help you or will it not help you? And then, further down the line, we have a working prototype. So we've embedded the model in a software system that we can then bring to where the radiologist is working. So this is one specialist looking only at a particular kind of chest X-rays from intensive care. And here we have, we can spend time with him understanding how his normal day is. And then we can show him the prototype and have him use that system similar to a normal day. And then we can also bring up some mock-ups of some other alternatives that we can discuss with him. So, trying to iterate a prototype, a system, so that it can be configured to that local practice or different local practices is very important to do early on if you want to have success, down the line. That last image. This is another example. So back to the, pacemaker patients algorithm. So we were designing a system for clinicians, but then in another follow-up project, we were also exploring how could we involve patients in generating, patient-reported outcomes when there is a prediction. So, and then the question came, how can we share the predictions with patients? You have a high risk of cardiac arrhythmia within 30 days. It's kind of a difficult situation to explain, without a condition being there. So we had a lot of mock-ups and, discussions around particular, experiences that patients have, and to be able to untangle, how will this work in real life. So the point here is just, you can start with paper and have machine learning on paper and bring it out early on in the project to get a sense of, is this a good direction we're going, or is this not a good direction? So I think the main point I want maybe to bring to you is to think about, bringing some early versions of the models, of the outputs of the models that if you're working with machine learning, bring that out to the clinician and have a discussion. Even 20 minutes is good, but do that continuously. Then you'll have more success with machine learning based systems. I think that's it.
So are there any questions for people? I've got something. Sure. So the bottom line here is we can create great algorithms in the lab and see that they work very well in diagnosing, and predicting, and whatever we do. But then when we made the step to move this in real life, in a clinical setting, everything falls apart. So you didn't mention at all certification and medical technology certification and protocols. So my question is this also a problem in introducing AI algorithms in medicine? And I'm asking this because we have seen AI proliferate in very different areas of daily activity, but not so much in health. So do you think this is also one explanation why it doesn't work on real life?
So it was one of my pillars. So this paper is based on a review of 25 papers that describe implementing AI in some kind of clinical setting. But none of them reported a lot on the regulatory aspects. So of course, it's a big thing. If you want to have the system adopted, you need to be approved. So I think the main point is that it will affect back on what can you then actually develop. So because it falls into different risk categories, right? And that's another thing I would encourage. If you are aiming to make a system that's implemented, then you need to consider the regulatory constraints very early on. Because it's going to affect the design of the end system. Because you're not going to. What can the model do? You can know that early on, but you can also anticipate, do we aim for this kind of use scenario? And if we do that, then it will fall into risk 3, category 3, and then a lot of regulatory process work needs to be done. So, but on the other hand, I don't think it's the reason why it doesn't work, because there are many systems that are actually approved, but they're still not used in routine use. So, it's a cumbersome work to get it approved, but even though it's approved, doesn't guarantee adoption. It's just they trust it a little bit more, but still they might not use it. So it's not going to solve the problem if you get it approved. It's just going to give more confidence in the system, maybe. And then it's also going to affect the design of the system. Like what can you actually make that's doable, you know.
Yeah, this is one area that we have really trouble in putting it in front of our students. That when we build something, let's say, oh, this is a clinician and wants some tool, I will just go and program it. It doesn't work like this. You have to do, UX by design, regulatory preparation by design, privacy by design. Otherwise, at the end, you end up with something that works for you but doesn't work for the people, and doesn't make any sense. So yeah, that was my point. Yes. Okay. Yeah. You want to?
So, due to the complexity of medical problems, how does AI separate the variables that are expected, unexpected in some cases?
So I just need to understand, so, fix
So, sometimes to fix, to recognize the problem. For example.
Okay, so you mean in complex clinical domains, they can be challenging for AI to.
For even anything else, yes.
Okay. So I'm not sure what I'm answering, but do you want to try again, or should I try to answer?
No, try.
Okay, let's try something. So, I mean, I think I had that point actually. Maybe I just go back. Okay, I'm not sure I had that one, but I'm gonna try to elaborate a little bit. So, I mean, what you're saying is that some diagnosis is complex, right?
They can sometimes that may be variables that are unexpected even for doctors.
Ah, yeah, okay. Do you mean the output of the machine learning?
For the problem, for example. You will go for a regular X-ray and you find out something that cannot be recognized.
Okay, I think maybe I understand a bit. I'll try. So, for example, in the X-ray project we have, right? We have different types of findings in the X-ray. Some, are present in a lot of the data set. So, let's say 10% of the data, it has this type of finding. Then maybe it's possible to train the AI to be quite good. But then you have, a rare finding, which is also important, like pneumothorax, for example. That's 1 to 2% of the findings. Then the AI model might be a bit weak in predicting that. Is that a little bit?
That's right.
Okay. Then the problem is that we only have the images to train on. But what a clinician is looking at normally is more than the image, it's the history of the patient. So what this tells us is that many times you need different types of data around the same problem to be able to have a good prediction. Oftentimes we think we just have a lot of images, that's good, but maybe it's not good enough. We actually need, patient history, the medicine of the patients that they take. So we need, multimodal data to be able to be good at the rare cases. But that's difficult to get for training purposes. It's even more difficult sometimes to get when you integrate it, because then you go from one hospital here to another hospital, and they have a different setup, and then you cannot collect the data in production, and then you cannot make the prediction.
Yeah, thank you.
I don't know if it makes sense. Yeah.
It appears that the validation of these AI models is focused on some specific medical fields, such as cardiology and radiology. How possible is it to implement? How possible is it to implement such models in more complex medical fields such as psychology?
So, like in mental health domain, I think actually. So in psychology, do you mean mental health issues, for example?
Yes.
Yeah. So I think actually mental health is actually okay because they have been going on for a long time and also collecting different types of data, that actually proved to be fairly good. I think there are some systems, running based on, for example, voice recognition, so they can hear on the voice on telephone calls, for example, the state of the voice compared to, when you go into a particular kind of mental state. So I think in mental health there's actually quite good progress. using different types of data. I don't know if it's more or less complex than cardiology, for example. I think they would not be happy in cardiology to agree that psychology is more complex. I think all domains can be complex depending on what in the domain you're looking at. Yeah.
Can we say that this technology is affordable for every person, or is something that at least in the beginning should be referring to rich people?
So, do you mean like what's the cost of implementing these systems? Or?
The cost of introducing this kind of technology in patients and hospitals. For example, when we approve a medicine, at first it's really its cost is really high.
Yeah.
So is it this kind of situation, or it's something that from the first from the day one we can have as patients?
Yeah. So I mean, I think it's again very dependent on the particular algorithm and what can it do. So the value of the algorithm and so on. And for example, in this AI for X-ray project that I'm part of right now, I discussed with the company because they have a electronic health record that they sell to hospitals in Kenya, in Indonesia, in Jamaica, so smaller hospitals in those countries. And I asked them, so what's the business case like? How are you going to charge the hospitals for this chest X-ray algorithm? And then they said, well, at the moment they don't believe that it's gonna, do more than provide some good value. So they're not gonna be able to charge for it. So it's not gonna cost the patient anything. But they may be better at selling the tool. So it depends very much on how expensive and how costly it has been to develop the algorithm, how costly it is to integrate it, and so on. And yeah. So I think you'll see different versions of the costs.
Okay.
Yeah.
But this is a very good question because we see it also in other areas like monitoring chronic patients at home, when the insurance funds claim that the value of monitoring them compared to the same hospitalizations, financial-wise, does not make a business case. Of course, it makes a case social-wise. So there's a big discussion whether this type of technology actually reduces or increases the cost.
Sure.
And I agree that it is case dependent, but it looks like in most cases it increases the cost at the end. Although in the beginning the whole discussion was that introducing this type of digital technology will reduce the cost. Because it will, save hospitalizations, it will lower the burden for clinicians and all this theory behind it, which doesn't prove to work in real life.
Yeah, I think that's
that cost introduction of a new technology question is a very valid question.
Yeah, so maybe it's this point, right? If you're not able to show that you can reduce costs in some way, sometimes, they are not gonna,
But the thing is that in health, there is a contradiction because every new technology costs more.
Yeah.
I mean, the latest MRI machine will cost more to do the MRI scan than the previous one. The new medicine, as you said, will cost more than the previous one. So this domain, which is totally different to whatever else we know, telecommunication, for example, every new generation of technology is much simpler than the previous one. So this area is used to pay more for newer things, but not in the case of digital technology, AI, and single person things. It's very confusing.
yeah, and I think also, the invisible costs, are usually not documented. So when you install, let's say, some of these examples I gave, all the quotes, they were maybe not part of how we measured the effectiveness of the system. It generated more work. They had to go and fetch the precision. They had to be careful when documenting, so spending half an hour more. All these things are maybe not documented. So it looks like, if you make a study where you show that, it might be more expensive, but over time you decrease costs. But then again, in the clinical setting, they spend more time using the system because they had to do many other things that they didn't do before. So it could be, not that easy to demonstrate cost effectiveness.
About that, but they take the time from something else. Yeah, for example, if I'm at home, I don't need a nurse right up me. And this time that they could use for cleaning, for example, they could use it using the system. I think that the profit is much, much higher that they can demonstrate its value. I mean, it's only profit, I think. Because the time, it's not that it increases the value. I don't know if I am understood.
Yeah, I think I understand a little bit.
Okay.
So, so you mean what do you spend the time on? Is that a little bit
Yeah,
like
that-
spending the time?
The timeline is the same.
Yeah.
9-5,
Sure.
8-4.
Yeah.
But you utilize your time in something else.
Yeah.
Not taking care of the patient.
Yeah.
But using the system.
Yeah. Sure, that's another, hidden, oftentimes invisible effect that I also saw in some of my work. The whole remote monitoring of these pacemaker patients. I did a study of what is it they spend time on in the clinic actually, and there was all this invisible work that I'm trying to explain. So, for example, now they have telephone hours, 2 hours a day, where patients can call in because they have 3,000 patients with the implant. And then they call in, my home monitoring box doesn't work. I think that's like 70% of the calls. So now they become, the nurses that used to talk to the patients, now they need to take a phone and just describe how the home monitoring box works. And, that's not part of the original, system or evaluation.
Okay.
If a faulty AI prediction leads to a wrong medical decision, who is to be held accountable?
I think that's the one question. Sorry?
That's the one we don't know.
Yeah, that's the one. But I think depending on where you are in the world and what legislation governs the use of AI and how the manufacturers got approval, and there are many things, right? And how the clinicians use it in that clinic, then I think it's decided. But I think at the moment it's very blurry. There's not clear, who's liable. Is it the company who made the algorithm, or is it who got approval, or which probably not, or is it the clinician using it? And what if they overrule the algorithm? Can then be used as an evidence against you, and so on. So I think at the moment it's not super clear. I think at the moment it's still the clinician who is ultimately accountable with or without AI. I think. But I don't think we've seen that many cases in court yet where, the AI said, I had cancer, but you said no, so what do we do? So I don't think this is surfaced yet because we don't have that many systems in use.
Nobody's using it.
Nobody's using it. Yeah. So I don't know, I don't think there's a clear answer to that, unfortunately. It's being discussed, I think, in EU and with the new AI and so on. That's a very good question. I'm laughing because it's a difficult question. That's a very good question.
There's one.
I would like to ask also if, as the researchers and the technicians, you have a word in the ethics regulation of your work.
Yes. So you mean what the, you know, so to get approval for the studies, like what are they doing or what?
I mean that with every new achievement, the EU, USA, UN have to make regulations, ethics regulations of its use. Do you have a word in this regulation? Do you have an opinion upon that, upon these regulations? For example, if the UN says that, okay, this kind of technology has these regulations, do you have an opinion to criticize or say something about these regulations and change them, or consider changing them? And the thing,
Yeah. So my first answer is that I actually don't know too much about the new AI regulations that are coming out. I don't know the details of them yet. But I think so. In the studies I've been part of, we write a clinical protocol similar to any other clinical study, and then it needs to be approved by a board, and they look through it, and then they approve it or disapprove it, and then it goes back, and you rewrite it, and then it goes back and forth until it's approved. And I think they are the ones at the moment that locally regulate at least the clinical studies, the boards, the ethical boards, in each country. Is that answering a little bit? Not really.
okay,
You
okay.
can ask me if I see any problems with the coming AI regulations or.
No, I am asking if positions like yours are enabled to have an opinion upon regulations in its work, in his or her work.
So you mean if researchers are invited into discussing the formulation of regulatory rules or.
Yeah, that's the question.
That's the question, yeah. So I definitely think so. I mean, I think it's been going on. So there's an EU AI Act or something coming up.
I think this is done now.
It's done now.
And there is a process of open consultation.
Yeah.
So in theory, the answer to your question is yes.
Yeah.
But in practice, I'm not so sure how actually this happens. I think it's mostly bureaucrats in Brussels and
Sure.
that draft the regulations. And maybe the industry. The industry definitely has a say in there because also they have the resources. But researchers, I don't think they're very influential. Let us put it this way.
Okay. Yeah.
I haven't been in mind. I've given a talk to the EU Council for Ethics or something. So they don't know the technical side, and so I gave similar talk about the challenges when it's implemented, and maybe my point to them was, but they're concerned about ethics, so they are discussing how can we implement instruments that ensure ethical concerns when you develop the systems. So I think they take away some inspiration to implement, that you need to do this and that to get ethical approval. But that was more like it wasn't a hearing for like a particular regulation. It was more inspiration.
I think the AI Act is 80% about ethics. What will happen if the machine decides,
Yeah.
what if the machine takes over? And this is
The whole challenge.
yeah. Well, I haven't read it,
No.
to be honest, but just as a feeling from the news. It's all about ethics. Okay, thank you very much. Let's give him a warm applause.